Good afternoon, everyone. I'm Dr. AIIMS Singh, Senior Resident in Department of Neuroradiology. Moderator is Dr. Sabyasachi Jain. Today, I'm going to be presenting a case of non-traumatic spontaneous CCF, which occurred due to a ruptured PTA aneurysm. So, starting with the history, carotid cavernous fistulas. So the history is 32 years female patient presented to us in AIIMS telling with the complaint of severe headache, 4 to 5 days. On clinical examination, the patient had chemosis and proptosis of left eye. The proptosis was mild and it was pulsatile type. There was no history of any artery, fall, trauma, or seizures. So the initial differential in view of the clinical history that we kept were the cavernous sinus thrombosis, retroorbital cellulitis, or carotid-cavernous fistula, that is CCF. The initial NCCT was performed in CT19 in Neuroradiology department. You can appreciate that there is no obvious evident SH here. There is fourth ventricle chinking, and there are signs of posterior fossa congestion in the form of chinking fourth ventricle, and there is a tonsillar herniation as well. The cerebellar folia, they appear effaced. So following these findings, we performed MRI in our department. See, these are the MR images of the patient. These are XLP2 weighted images. These are ASL images. This is MRV, and this is XL flare images, and this is the top MRI. We'll discuss the findings in these images one by one. So here we can see that right cavernous sinus, in fact, bilateral cavernous sinuses are bulky, and there are few flow voids on right side and the right side of the cavernous sinus. And if you can appreciate, there is mild left-sided proptosis. On slightly higher section, we can appreciate that the left SOV compared to the right SOV is dilated, and this could be, we thought this could be CCF. So we performed the ASL imaging as well. You can see that there is arterialized flow in both the cavernous sinus and in the left SOV as well. So MRV was followed by this. MRV, we didn't see any evidence of CVT. Axial flare images, the retroorbital fat was normal, optic nerves were normal, that essentially cleared out the retroorbital cellulitis. And on top images, another finding, that is secular outpouching of cavernous ICA was appreciated. We initially thought it was a cavernous ICA aneurysm which had ruptured to cavernous sinus, thus leading to formation of a CCF. Interestingly enough, this outpouching is on the right side, while the patient had the symptoms on left side. So following these MR findings, what we did the DSA of the patients in our lab. So these are the right ICA runs in arterial phase. We'll discuss the anatomy of the CCF one by one here. These are AP, these are lateral, and these are oblique images. This is right ICA, which we have catheterized. This is ACA, and then this is MCA. In the right ICA injection, we can also appreciate the filling of posterior circulation, which is a bit unusual. Because there is no PCOM here, it is filling via persistent trigeminal artery, which is better appreciated in the lateral views here. We can also appreciate that there is a small outpouching in the posterior aspect of this artery, and there is filling of cavernous sinus as well, and there is filling of venous circulation on the arterial images. On the left side, we can see this faint filling of left cavernous sinus, and then there is this left IPS, that is inferior petrosal sinus. On the obliques images, we can appreciate the same. This is the PTA aneurysm, and then this is contrast blushes cavernous aneurysm, cavernous sinus. Then on the venous side, the venous anatomy is better appreciated in these images. This is the cavernous sinus, which is filling from the ruptured trigeminal artery aneurysm. This is SOV, and then this is IOV. SOV is superior ophthalmic vein, IOV is inferior ophthalmic vein. Then this is the IPS, which is draining into the internal jugular vein. This is transverse sinus, which is also draining into the jugular vein. On AP view, we can see that on left side, SOV is retrograde filling, and then this is IOV, that is inferior ophthalmic vein, and then we also see some filling of IPS, which is draining into the jugular vein. ECA runs were essentially clear on both right and left side. On the vertebral artery run, we can see basically the conventional anatomy, except for one single vessel which is present between anterior inferior cerebellar artery and superior cerebellar artery. This artery is the posterior aspect of the persistent trigeminal artery that we appreciated in the AIIMS as well. So this is the schematic representation how a persistent trigeminal artery aneurysm looks like. This red colored is the ICA. Between ICA and this basilar artery, there is a communicating artery which is persistent trigeminal artery. This purple colored is the aneurysm, and this has ruptured into the cavernous sinus, retrogradely filling the inferior petrosal sinus and superior ophthalmic vein. The filling of superior ophthalmic vein in this case is causing proptosis, and hence the clinical symptoms. This was the 3D rotational angiogram that we obtained in our lab. Very well represents the anatomy. This is our catheterized right ICA. You can appreciate there is a focal outpouching here arising from right ICA. This is the PTA aneurysm. And if you appreciate, this is the right cavernous sinus, this is intercavernous sinus, this is left cavernous sinus, and from left cavernous sinus is emanating left superior ophthalmic vein and left inferior ophthalmic vein. So anatomy, I hope, is very well clear to us. So in view of the ruptured PTA we are having, intervention of this patient was planned. We planned coiling of this patient using echelon microcatheter. We first catheterized right ICA with neuron 070 catheter, and the balloon that we took was hyperglide 410, and with this is the balloon represented by these and this markers. And this another microcatheter that is going into the aneurysm is the echelon 010 microcatheter. After cannulating the aneurysm, we coiled the aneurysm site as well as we coiled the IPS and the cavernous sinus L as well, thereby eliminating the aneurysm, IPS and superior ophthalmic flow at the same time. These are the immediate post-ambo runs, post-coiling runs that we took. We can very well see the anatomy here. This is the right ICA run. We can appreciate the filling of persistent trigeminal artery and the posterior circulation. This is basilar artery, PCA, SCA, and this is the basilar trunk itself. We can see that there is no cavernous sinus filling in this case. On the lateral runs, there is significant stasis noted in the inferior petrosal sinus. So post-op day 1 after extubation, patient had significant relief in headache as well as left-sided chemosis. He was discharged in stable condition after 2 days with a significant relief in symptoms. Check DSA was planned after 4 weeks. This was the check DSA that we did after a month, approximately a month of surgery. We can appreciate it in these right ICA runs. There is no evident filling of cavernous sinus, no filling of SOV, there is no filling of inferior petrosal sinus, and this persistent trigeminal artery is spared because it is supplying the basilar circulation, posterior circulation. It had to be spared in this case, and it is very well filling in these images. These are the coil mass which is seen in situ in the cavernous sinus and in the aneurysm. So, caroticocavernous fistula associated with the persistent trigeminal artery is a very rare phenomenon. Persistent trigeminal artery is itself very rare, with incidence of only 0.1 to 0.6%, and an aneurysm of this and association with CCF is even more rare. However, it is an important cause of spontaneous CCF, and in PTA cases of persistent trigeminal artery, there is high occurrence of the aneurysm, and this is due to 2 reasons. First is there is inherent congenital weakness in the middle layer of the PTA. And second, there is something known as short circuit effect, because there is acute angulation between a large ICA and a very small persistent trigeminal artery. It creates a suction kind of effect into the PTA, and thus there is hemodynamic stress at this location. This causes the formation of aneurysm in persistent trigeminal artery. So there are 3 types of persistent trigeminal artery according to Salzman. In type 1, ICA communicates between the basilar trunk and the PTA, it forms a connection between the ICA and the basilar trunk itself. In type 2, there is communication between the distal basilar trunk, and distal basal trunk is hypoplastic. There is fetal PCOM. To note here is the fact that in these cases you have to preserve the PTA because it is the only fully solely artery which is supplying the SCA, and if we sacrifice PTA in this case, the basilar circulation is going to go and there is going to be a big pontine infarct. And then there is type 3 where ICA is communicating between the where PTA is communicating between ICA and SCA. These are the various case reports from various different authors who had treated similar cases. Initially, there was treatment when coils are not available. They used to treat with balloons or ICA ligation. But since the advent of coils, most of the cases are being done with the coil itself. So this was rather complex case of CCF with the rare arterial variant, which is persistent trigeminal artery, which complicated the overall management in our aneurysm. We had to go out of the box. We had to do three things. We had to coil the cavernous sinus, SOB, IPS, and the aneurysm at the same time, while we had to preserve the PTA. Thank you. They completely abated, sir. After 1 month, they completely abated. Process is relieved. Patient is under clinical follow-up.
So this was Sarchman type 2.
This was the artery in our case was Sarchman type 1 because it was between SCA. We prefer not to say. Yes. Matlab, would have been, but.
The PCA was fetal or adult?
No, sir. It was filling from basic as we saw in right PA. Adult.
Patient with PTA present with SH or they are not present with SH?
They can present with SH. The part of the artery which goes to the cavernous segment, if it ruptures, if the aneurysm forms there, only then they present with the CCF. After that, they can present with SH. Let's say the aneurysm forms between its junction between the basilar artery and they can present with SH. Sorry.
Stories there.
We'll plan elective embolization. They have to do because there will be symptoms of leptosis and leptinosis, which will be very troublesome for the patient, and there will be tinnitus as well because of the filling of IPS. Asymptomatic.
So, under only 58% said to be present. Not just CCF, not secondary to aneurysm, but primary CCF, originating at the origin of PTA and then giving CCF. So we plan on actually treating it very well. We had published a case report, not that time, but that time we had a uniform aneurysm of the PTA, and we had put in that time with all these things on we did targeting for it. So that is the origin of PTA. Biologically is written from the aneurysm.
Thank you.